Good afternoon, everyone, and welcome today to the webinar that is going to be speaking about minimizing risks in medication, nutrition, and immunization strategies for children and adolescents. And this is the second in the series. Just to give you a background, the World Health Organization organizes a theme on September 17th, 2025, which is the World Patient Safety Day. And every year it gives a new theme. For this year, it is safe care for every newborn and child. And the tagline for this year's theme is patient safety from the start. And as we know, because children are unique, they are young, and they are not able to speak for themselves, harm during care for children is often not observed as it is in the adults, and sometimes it goes undocumented. It also highlights the urgent need to prioritize safety in maternal, newborn, and child health services across all healthcare settings. And strengthening safety in these areas is essential to protect children's health and uphold their right to safe, effective, and compassionate care. Having said that, we do know that the Government of India has several programs to protect children and to provide them with essential services in the early days of their life. And particularly the first 1,000 days are critical to child's growth, development, immunization, and optimal nutrition. And we do have several programs that are able to provide these effective services in the first 1,000 days. So whether we speak of Mission Indradhanush or Poshan Abhiyan or several programs under the National Health Mission, programs with the women and child development, these are integrated strategies to improve child health, and these efforts focus on safe immunization practices, infant and young child feeding practices, malnutrition, food safety, etc. However, we still see that there is a lot of harm that is happening. So much of it is documented, some of it is not documented. And what we are trying to do through today's webinar is to bring three experts with the objective to promote evidence-based safe practices in immunization. So we will hear from the experts as to what is already happening, what is not happening, and how best to strengthen the systems. How do we raise awareness on age-specific needs and importance of providing appropriate care at each stage of development? How do we strengthen the knowledge of healthcare providers and caregivers in preventing errors and minimize risks in child and adolescent care? And to promote the integration of safety principles across all pediatric and adolescent health initiatives. So this is an open webinar, and we invite everyone who is interested in the topic to join and listen to the experts. A little background on why do we do this? We are a not-for-profit organization working in non-communicable diseases, rare diseases, and patient safety. Under the patient safety flagship, we have a program called the Patient for Patient Safety India, which comes under the larger umbrella of the Patient for Patient Safety Asia Pacific. And this is an informal coalition of patient groups and patient advocates who believe strongly in high quality health systems that ensure safety at every level. So may I please introduce Dr. Ajay Khera, and if I can have his slide, please. So our first speaker for today, and we have a slight change in our agenda as the other two speakers will be joining us a little later. Dr. Ajay Khera will be speaking on the topic of nutritional safety and breastfeeding practices across developmental stages. And I've had the privilege of working with him long back. He has a very rich and diverse experience in the field of maternal and child health. And he's the country representative of Engender Health and previously the Commissioner for Mother and Child Health, including adolescent health and immunization at the Ministry of Health and Family Welfare, Government of India. He's a graduate with a postgraduate qualification in public health with more than 25 years of experience. And some of his highlighted areas of work are more than 25 years of experience in various government health programs at the Ministry of Health and Family Welfare. At Engender Health, he's responsible for designing and implementing projects that lead to lasting improvements across the spectrum of sexual and reproductive health, etc. And prior to Engender Health, he served as the Commissioner for Maternal and Child Health and also served as the Deputy Commissioner for Immunization Program. He has several publications to his credit, and I warmly welcome him to this webinar and thank you for agreeing to come as an expert speaker. And I hand over to you to speak about nutritional safety and breastfeeding practices across the developmental stages. What can we do? What are we doing already? What can we do better? And how do we ensure better safety practices? Over to you, Dr. Kera. Have we lost him?
Yes, yes. Um,
Okay. Because if you can show the panelist screen, Dr. Thakur will be joining us later and I will introduce him. And if you can connect with Dr. Kera to see whether he has a problem of connection or an internet issue.
yes, ma'am, I'm connecting with him.
Because please move back to the panelist screen. So while we get Dr. Ajay Kera back, I will speak a little more about the work that we do as Patient for Patient Safety Network India, as well as a Patient for Patient Safety Network Asia Pacific. We work on several thematic areas depending upon the guidance from the World Health Organization for the year. Apart from that, we work with patients and patient groups to help them understand safety issues across the healthcare spectrum. Welcome back, Dr. Kera. Sir, you're muted.
Okay. Yeah. Actually,
Thank
I
you.
got disconnected in between.
No problem.
Then I started getting connected with my mobile phone. But now I'm again back. So should I
No
start?
problem, sir.
Should I
Yes,
start?
sir. Please go ahead. Please go ahead.
No, thank you very much. First of all, greetings to all of you on behalf of Engender Health. And I'm really grateful to the organization for giving me this opportunity to speak on a topic, which links with the child survival. And as you know, we are all aware that globally as well as in India, we are committed to improve the child survival rates in the country. And there has been a lot of improvement, but there is still, kind of a lot of scope for, making, further improvement in the child survival in the country. And today, because the topic which is given is, patient safety from the start, and my focus of attention is in the context of nutrition. I know there are so many kind of a patient safety measures which can be put into practice, whether it is drug interactions or medication or it is immunization. And similarly, nutrition is so critical to the health and well-being of each and every human being, and particularly I think for the health and survival and development of the children, the proper nutrition is very critical. So today I'll talk about what could be the related issues around nutrition which must be addressed in a targeted fashion so that we can really improve the child survival and well-being in the country. And I will also start with the fact that when you talk about child survival, 50% of the the child mortality is in the backdrop of child undernutrition. If the child is malnourished, the 50% mortality happens in the backdrop of nutrition. I mean, we may declare child has died of pneumonia or died of diarrhea or died of a vaccine preventable diseases, but in the backdrop, it is the undernutrition. A normal, healthy child who has a proper nutritional status may survive that attack of the pneumonia, but an undernourished child, may not be able to survive. So that means what I'm trying to say is that nutrition is very, very critical. Now, in order to address this nutrition in children, we keep talking about 1,000 day of life, which basically talks about nutrition in pregnancy. It also talks about nutrition during the first 2 years of life, that include 1,000 days. So I'll try to focus my attention on the nutritional safety or the nutritional improvement plans which should be kept in mind, so that we can really improve the nutritional status and thereby make a change in the child survival rate. Now, immediately, after the delivery of a child, the newborn, the most powerful intervention which really helps in improving the nutritional status of the children or a particular child is the early breastfeeding. And early breastfeeding is so critical that it should start within 1 hour of the birth. Early does not mean 12 hours or 24 hours. Early means immediately or within 1 hour of birth. And this is a kind of indicator which is continuously observed. And I will like to mention that as on today in India, out of 25 million births which are happening across the country, you can say around 55 or 56% of the children, the early breastfeeding happens in. That means within 1 hour. So rest of the 45%, you can say even rest of the 50% children do not get that kind of a education awareness, or the mothers do not get aware, and or because of various reasons they are not in a position to do the early breastfeeding. And most of these reasons are preventable, and I will try to put it in the category of patient safety or women's safety measures. And I'm sometimes feel so surprised that as on today, if 90% of the deliveries are happening in the institution. I know that saying is very simple that you go for a early breastfeeding, but we also understand the agony of the mother who has just delivered or who just had a cesarean section, and then we are asking them to feed a child. Theoretically you may feel quite a challenging, but practically it's possible. It's only the mindset. Even nowadays, even following cesarean section, even on the operation theater, after the newborn is taken out from the abdomen after the operation, the newborn is put on the breast. So that is the kind of the practice. And this is a practice which is a evidence-based practice which can help in reducing the newborn mortality by, let's say, 15 to 20%. I mean, there is no intervention, which can reduce mortality, newborn mortality to such an extent. And breastfeeding is such a powerful intervention. Now, beside, the reducing the child mortality, it also have, multiple benefits. It also helps as a benefit in terms of, improving the cognition or the so-called the intelligence quotient of a child. It also helps in reducing the long-term, non-communicable disease in terms of obesity. So breastfeeding is called as the, first vaccination of the child. It is such a powerful intervention. So that's number one. And then the second, the important point which I want to highlight in the context of, breastfeeding is that it is not that only early breastfeeding, it is also the exclusive breastfeeding. Now, exclusive breastfeeding is what? That for first 6 months of the birth, after birth, the child has to be given only breast milk, only breastfeeding has to be done. No water, no milk, no kind of top feed or anything of any kind. Exclusive means totally exclusive. Even no mixed feeding. I know that there is a practice in many of the societies, maybe the high societies you can call it. They prefer kind of mixed feeding. In the night time they say mother has to take rest, so it is better to give a kind of a bottle feed or kind of an artificial feed. But that artificial feed, if you provide in the night time, just to provide rest to the mother, it basically impacts the overall physiological system of the breastfeeding, and then the whole breastfeeding gets impacted. And then so many the kind of the, I will call it, side effects of the formula feeding or a top feeding happens, that the child will have more of an episodes of pneumonia, more episodes of diarrhea, more episodes of non communicable disease, let intelligence quotient. And then there are so many benefit even to the mother. People don't count those benefits. These counts are one of the count, the important the benefit to the mother is because there is something called as the postpartum hemorrhage. Postpartum hemorrhage is a common problem after delivery, and if the mother follows the early breastfeeding, exclusive breastfeeding, then the possibility of a postpartum hemorrhage reduces to a large extent. The anemia, possibility of getting anemia also reduces to a large extent. And this also acts as a method of contraception. It is a contraceptive. Breastfeeding is a contraceptive. If mother is feeding a child, this method acts like a contraception for next 6 months. And even the so-called the mental kind of psychological development of a child also improves. So there are multiple benefits both to the newborn as well as to the mother. So that means early breastfeeding, exclusive breastfeeding must be practices. This is an evidence-based intervention which can really improve not only survival but overall mental and psychological development of a child also. That is number two. And then there are number of misconceptions which are in the minds of the people, which I will like to highlight, which public must know. As a healthcare provider, we must know and we must advocate. And there is something called as the colostrum. Immediately after the delivery, it is not the milk which comes, it is the colostrum for the first 2 or 3 days. And there are many communities, many societies which discourage colostrum intake. But colostrum contains a lot of antibodies. It's a very powerful kind of a, it is a kind of you can call it a real strong vaccine to a child. It is like an elixir. So that must be promoted. And the practices like pre-lactal food, because generally you must have seen in the community that
We'll wait for Dr. Ajay Kheda to join. I think so. He got log out. So you are on mute.
am I audible?
Yes, sir.
Okay, so I don't know what is happening today. I think net is going and coming, but doesn't matter. So I'm
Yeah,
sorry.
No
yeah, no
problem.
problem.
So I was talking about three important things. One, I spoke about early initiation between the first hour of the birth, and then I spoke about something about exclusive breastfeeding, and then I also spoke about something which is called as the colostrum. And then the third important thing which has to be kept in mind, that is complementary feeding. And then complementary feeding is the feeding which has to be started at the 6 months of age. And if I share with you the present data sets, the complementary feeding practices is followed roughly around, again, 50 to 60% of the women, the mothers, follow that practice. But the real quantity and the quality of the food which is provided during complementary feeding is being provided by less than 15% of the mothers. So complementary feeding quality and quantity is a big challenge in India, which is also one of the root cause for undernutrition in children. And we are all aware of the magnitude of the problem of undernutrition. Around 40% children in India are undernourished. Around 50% or 60% children are anemic. So unless those complementary feeding practices are followed up properly, we may not be able to improve the nutrition level in the children, and which can impact the overall health and well-being of the children. So these are some of those points which I really wanted to mention. But I simultaneously I will also like to mention that there are some kind of a desirable practices which should be put into practice if you really want to promote breastfeeding, because breastfeeding, exclusive breastfeeding, complementary feeding, it doesn't happen automatically. We have to invest time and energy, and we have to support this practice. That's why we say breastfeeding has to be supported, it has to be protected. And I mean, the protection means you must be aware that there is a something called as the Infant Milk Substitution Act 1992, which was initiated by the government of India to promote and protect breastfeeding by enacting the legislation which says that no promotion of the infant milk substitutes. I don't know if you remember, maybe 10, 15 years back or 20 years back, there used to be a lot of advertisement on this uh, infant milk substitutes, very healthy baby being shown on the lactogen kind of a box. But now all these, practices, promotions have been banned because this, motivates the mother to, buy that kind of a formula milk or a infant milk substitute, which is not a healthy practice. So that means the government of India has also come up with a legislation, but that legislation needs to be implemented, which is called as the protecting breastfeeding. And even there is a no promotion has to be done with the doctors, nurses, and the healthcare system, and there should not be any misleading kind of a advertisements, which incites mother to buy that formula feed. So that's a kind of a big practice. And keeping that point in mind, even the world breastfeeding is also being celebrated, which is going to be the next week from 1st to 7th of August every year. This is being celebrated across the world, which is called as the breastfeeding week. So these are some of those things which I thought will be important. But then before I close my kind of a discussion on this issue and invite questions, there are I was talking about few practices, and the practice number one is that breastfeeding just doesn't happen just by saying to the woman. They have to be counseled, and they have to be mentally prepared right at the antenatal period. It is not that time when the pregnant delivery has happened. It is during the antenatal period a counseling has to be started.
Things like there's something called as the rooming in. Rooming in means the newborn has to be put just near to the woman, maybe on the same bed. It is not that child has to be on a separate cot, rooming in, near to the mother, as close to the possible. And there is no kind of no pacifiers, no pre-lactal feed, and baby has to suck frequently at the breast. The mother has to be provided privacy, whether at home or whether at the workplace. And mother is to be stress free. Government of India is giving maternity leave. So there are provisions, but maybe in the informal sector that provision is not there. So mother has to be stress free, because stress has a very close association with the breast milk outcome. And no bottle, no artificial feeds have to be provided. So these are some of those practices. And then in terms of the frequency, breastfeeding on demand has to be practiced. And normally, after every 2 hours, this practice has to be done. And night breastfeeding is more important, because the amount of the milk which is generated in the night time is much more than the daytime. So these are some of those points which I wanted to share with you, just as a kind of patient safety measures or women safety measures to improve the nutrition health of the children. That's all, and thank you very much. And I'm sorry
Thank
for
you.
this technical glitch in between. Yeah.
No issues, sir. It happens, and especially during the monsoons. And you raised some very startling, numbers in terms of statistics, saying that only 50% are able to have an institutional delivery, and about 50% or 45% of children are undernourished. Um, a lot of them are not immunized. A lot of issues that need to be addressed to have safe childhood, if I can use that terminology. And there are a few questions that I would like to ask, but before that I would like to welcome Dr. Thakur. Thank you, sir, for joining us today. And Vikas, if I can have his introductory slide. Thank you so much. So Dr. Thakur is the Executive Director of the International Pediatric Association, and his current affiliation is the Director at Deep Children Hospital and Research Center at Gandhidham. He's a scientific committee member and a member of the India Expert Advisory Group on Measles and Rubella. He's the Vice Chair, Steering Committee, Global Advanced Vaccinology Collaboration, and a member of the PMNCH Board. This is the Partnership for Maternal and Child Health, and a member of the steering committee of the International Collaboration on Advanced Vaccinology Training. He has been instrumental in a lot of policy decisions. He has contributed immensely to the well-being of children in India, and has several major achievements to his name, including being the torchbearer of India by the Economic Times ET Edge, and the FPH's Foundation Day Award, Foundation for People-Centered Health Systems. He's a top influencer for the fight against polio, and received an outstanding Asian Pediatrician Award. Thank you so much, sir, for agreeing to give us your valuable time today. And Dr. Thakur will be addressing vaccination and sepsis prevention, and I think it comes very well after Dr. Khera's revelation on the statistics about vaccination in children and institutional deliveries, and why sepsis prevention is extremely important, and how can we minimize risks while maximizing protection in children and adolescents, and sepsis, especially in the concept of undernutrition and not enough feeding happening. So thank you, sir, and over to you for your insights into the topic.
Yeah, so thank you so much for this opportunity. I'm sorry I joined late and still
No,
trying
sir.
to catch up. So as I feel, I agreed that I will be talking related to immunization. And when we talk about minimizing risk, so thanks to the say now a very robust system in place, that we have a very good immunization system, a very well structured where we have minimized risk to the minimum. I remember, and I will give you some example that, and Dr. Khera knows that well. Sometime it happens, and it happened in my city, Gandhidham, when measles vaccine was administered, and 4 or 5 children died immediately after that. And Dr. Khera came here for investigation. And finally, we found out that this was something, a diluent error. So we have come a long way when we were using all those syringes, and now we use auto disable syringe also, and disposable for a long time. But still, sometime it happens, and we have also learned on that way. So it's very important that we are very careful when we administer immunization, because immunization is given to the healthy babies, and it's not a medicine that people are sick and they will accept some side effects. Here it is given to the healthy babies, and any such incidents, I remember after that there was a reflexly, every time when it happens, government used to that time say we stop the all immunization, and we send back the vials for testing. But we as a pediatrician that time we said no, if we are not immunizing it will be doing more harm, and we continued to immunize, recommend. And still now I don't hear such incidents. So we have learned from the past that we have to be very very careful, and diluent which look like some drug looks like diluent should also be not, it should be avoided. So we have learned. Another thing is adverse events following immunization, which is what we call AEFI. Now we have a very well AEFI system in place, where and it's not that it's a really is there really any serious side effect or anything, but there is a whole definition and investigation which comes into the place once it is comes under the AEFI. And those AEFI are say analyze, feedback is given. So immunization system has really evolved over time to a very robust system, and still we have to be always careful, and all the guidelines are there. I think you have already talked about sepsis in the last webinar. I talked to Mohini, and but as I said, I will be very happy to answer any questions related to immunization. Dr. Khera is already here, who has led the Indian immunization program as a Commissioner of Health and Immunization for a long time. But I will be happy as a pediatrician to answer if there are any question. And I'm really sorry, it's very not a very good day here, and work as well as some other issues are will not be able to be here for a long time. So if you have any questions for me, I will be very happy to answer.
Thank you, Dr. Thakur. And as you said, our immunization program has evolved over the time and has become more and more robust. However, our statistics still do not, give us a very good picture in terms of full immunization. And we do lose a lot of children after their first dose, especially those that are given within the hospital after an institutional delivery. And this is also a very large problem with migrant populations, especially in the informal sector. And we do not have a track and trace mechanism to find out where these children are and how they are lost. So, what do you think could be done to be able to ensure that children who are traveling with their mothers or families to places beyond their place of birth are actually tracked and their immunization status can be upheld so that whichever state they travel to ensures that their immunization is complete.
Yeah, so you are right. We have not achieved, say, we have not been able to immunize 100% children. And for that, again, Dr. Khera is here, who was also architect of Mission Indradhanush. And we have, with the successive Mission Indradhanush and these campaigns, we have bridged the gap, and that's a very good example for the world. How we did that. And now we are, you must be knowing, we are now moving from what we had for during COVID to now UWIN, and gradually every family, every child will be captured in that. It's a work in progress, but still a lot of work is being done. And migrant children are always a problem. My lifetime work is on polio eradication, and that's always a problem. But still, India has done a tremendous job, and by now capturing every child through digital tools, we will be able to do that. But till that time, there are mechanisms in place where, and these campaigns also, they pick up these children, because it is targeted for those children. And yes, now there are a lot of studies, lot of work is being done in what we call as zero dose children. Zero dose children means those who have not received the first dose of DPT. PPT, because see, we have largely now institutional delivery, and BCG, oral zero polio dose is given there, hepatitis B if required. But if they are not taken DPT-1, it means they are not in contact with the health system. And that's why a lot of work is being done. There are good studies available from India, that who are these zero dose children, how we can reach them, how, and see, this is, immunization is a building block of primary health care. No other intervention reaches to the community like immunization. In polio, we have reached to the 99% of the children, because otherwise it was not possible if we had to do that. But that time we just administered 2 drops of life and came back. We never asked how are you, whether you are immunized or not. Then we learned, and this all Mission Indradhanush, intensified Mission Indradhanush, they are all derived from what our learnings was in polio, microplan. These all those learnings were utilized. So now, for with this zero dose strategy, we will be not only reach to those children, but also connect them to the health system where they can utilize all the services of health system. The problem is they are not in contact with health system, whatever regions. For a long time, we just said 3 regions for not immunized: AFI, time not convenient, or some, the vaccine not available, or all those things. Now we realize there are many other factors which affects these community to be marginalized, and by reaching to them, we will not only immunize them but connect them to the health system, so we can deliver and really achieve universal health coverage. So I don't think we can discuss all those, but a lot of things are happening. Good work is being done everywhere, including UP and Bihar, which has lagged in past. Maybe very soon they will surpass the other states in immunization, because so much good work is being done there. So definitely we have to reach those children, and we are doing everything whatever is possible.
Thank you, sir. Two more very quick questions before I go to Dr. Bhaumik for his intervention. One, you are a pediatrician, and we do know that under the government's immunization program, there are a set of vaccines that are given to the children free of cost in public health institutes. However, if you go to the private sector, there is a far bigger choice, and a lot of times pediatricians do recommend vaccinations. Which of those vaccinations, in your opinion, should also be part of the national immunization program, and what kind of benefits will they bring to children to support safety and reduce sepsis?
See, every vaccine is most welcome, but see, there are two things. One is the individual protection, and second is public health.
Yes.
You know, if Prime Minister decides today, I want to give 1 rupees to each person in the India, how much it will be? 1.4 billion, right? So, public health, you see what is, what is in larger interest of the population. So we always confuse that, and individual protection. Yes, you have many vaccine which can be which are given in private sector, but we have to prove when we go to the policy makers, we have to prove what is public health benefit. Like in government sector, we have MR. In private sector, we have MMR. In private sector, we also have, say, typhoid vaccine, chickenpox vaccine. We have Tdap vaccine instead of TD. But we have to prove, say, public health benefit. It's so nice to see Dr. Khera. I remember when we were discussing about polio, and we advised that we should do this, and he as a public health expert, he challenged us to tell us what the difference does it make. So we have to prove to him that this is the impact which will be there. So you cannot there are more vaccines coming up, and government has to prioritize. And another thing is, India is such a big country, we cannot we just cannot include everything and roll out immediately. Like we have to see how much is the public health burden of the disease, how much is the morbidity, mortality, what will be the economic value, overall value, all that. And it goes through a very process, great process, where then it is launched and then gradually. So India has now increased from 5 vaccine to say how many, 11, 12 antigens in the, and there are many more coming. So as a pediatrician, see, so one family which is coming to me, they don't mind money, but they don't want his child to have even fever. So for that they can spend, but government cannot spend for that. Government will try to see that we reduce the mortality, we reduce the burden on the health system and everything. So gradually more and more vaccines are coming, and gradually being rolled out in a very good phased manner, because it's very tricky if you give it again, when we rolled out Penta, there was some incidents in Kerala, which again Dr. Khera has tackled that, and so it's not. We have to be very careful. So the private in office practice, and that is different. But if you ask me as a pediatrician, I would like to see every vaccine in the government schedule, and same schedule for the both. But if it is not possible, at least I would prefer we have typhoid vaccine because there is a burden, but you have to prove it. I would like to see the dengue vaccine in the system. HPV, it's an overdue announcement in the budget, lot of fanfare, but now it's I don't know why it is getting delayed. Then definitely in future, I would like to see RSV, which has significant burden still of bronchiolitis and pneumonia, and also more progress on the maternal immunization. I would like to see, if possible, flu, TDAP already we are, I think we are giving, otherwise we should give
Yeah.
that. And then in future, RSV, that's a good vaccine which has to come, but we have to see what we have achieved, and
Yeah.
what are our main problems, and gradually we have to go in that direction.
Agreed. Thank you so much. And with apologies to Dr. Bomik, one last question because Dr. Thakur has to leave. So you mentioned sepsis, and I was at a recent workshop by ICMR where they were talking about 10 medical emergencies, of which one of that was neonatal sepsis. And so it was a design workshop, and the reasons for children dying was that not only was sepsis not recognized fast enough, but also there weren't robust referral mechanisms, and primary healthcare wasn't strong enough to manage neonatal sepsis. So, in your opinion, what do you think we can do to improve that system, and how do we prevent deaths by neonatal sepsis, which is totally manageable if it is diagnosed and managed in time?
See, neonatal sepsis occurs in, where you have maternity homes, and I will reply, but you should also ask Dr. Khera, who is also a
We will.
gynecologist, and he will tell you how we can prevent neonatal sepsis. But it's a very clear that good practices during labor and after delivery in handling newborns, that has to be taken care, and staff has to be trained in recognizing neonatal sepsis, which is not same as the sepsis in the older children. You may not have fever, you may have hypothermia, you may have off feet, and then system now it's gradually expanding where the children they get help in secondary level care and SNCUs and everywhere. So it is most important is prevention. And for prevention, as I said, everyone has to take care, particularly from our colleagues who conduct delivery, and also those who are there. And from pediatrician or from the health workers point, we should be able to recognize, and we must see that the symptoms are not same as the others. You have a high index of suspicion and timely referral. There are many studies where they have used a dose of antibiotic and all that, but I think India is a well developed now. I don't consider it as a developing countries as far as health is concerned, and we should give our newborns best of the care, not on suspected sepsis and all that. Find out, we have developed a good referral system now most of the places, with this 108 and other systems, and government is providing support, so they should be taken to a center where they can be given investigated, and early diagnosis is also important. Suspicion, early diagnosis, and proper treatment they should get.
Thank you, sir. Thank you so much for your time. And we are really grateful for you, for your insights and for your, generosity in sharing your information and experience. Thank you so much. I'd like to now welcome Dr. Subhrajyoti Bhaumik, and he's an old colleague. I've worked with him several times on the issues of patient safety. It's my privilege to welcome and introduce him. He's a pharmacologist with over 17 years experience of clinical research and medication management. Was attached to Stanford University School of Medicine and has a fellowship in healthcare quality from ISFA UK. He's also a fellow of the Royal College of Physicians of Edinburgh and an ISFA Lucian Lee Patient Safety Fellow. He has so many accolades to his name, and we've worked together to make Patient Safety Day a success several times across the last few years. So thank you so much, Dr. Subhrajyoti, for joining us today. And it's over to you to speak about your favorite topic, which is medication safety in children and adolescents and preventing errors and managing adverse events. So thank you for joining us and welcome.
Thank you, Dr. Ratna Devi, for this kind introduction. Just want to, make one correction there. I've become a professor in pharmacology now. It's a hard-earned thing. So thank you once again to the organizers for inviting me here. Let me share my screen. Today,
Congratulations.
thank you so much. Thank you. So, ladies and gentlemen, today I'm going to, over the next, I have only probably 10 to 15 minutes time. I'm going to look at minimizing risk in medication strategies for children and adolescent, and greetings from KPC Medical College in Calcutta. It's an honor to be here because with Dr. Ratna Devi, we have done a lot of work in patient safety, and I'm really, really proud what Ratna Devi is doing in this country because we need much more people, many more people champion like her to champion the cause for patient safety. So today my session is going to be on introducing what errors are and believe it or not, what kind of errors happen in our pediatric population and what kind of medication safety issues can we take care, because this year's focus is to have safe medication, to have safe child and a safe mother. And I'll speak about something on medication reconciliation, which is something which is not spoken about, and we'll conclude with future strategies. So, as you all know, and I'm sure my previous speakers have highlighted that childhood is a very, very difficult phase because adolescence and childhood, a lot of growth is happening in these young people, and very importantly, medication is required in them for certain physiological and pathological process. And the developing physiology of children and the rapid changes in adolescence demand precision, vigilance, and evidence-based protocol. This is something which is extremely important, that, we need to be vigilant of our children. If we really look at how people change, how our young human beings change from the time they are born till the 18 years of age, you will be astonished if we remember our own childhood, how we were barely able to sit and then we were able to run so fast. There's a lot of physiological change which happens in a newborn to a toddler to a child, and with this physiological change comes the changes in the pharmacokinetics and the pharmacodynamics, meaning how medications are managed in the body. So there's a lot of change happening in the liver, a lot of change happening in your kidney, a lot of change happening in the blood circulation. So why are we talking about medication errors? Because the WHO way back in 2011, along with World Bank, came out with a report which said that 0.7% of the total health expenditure, which was at that point of time, this is pre-COVID data, ladies and gentlemen, was 42 billion US dollars could have been saved worldwide if medication errors could have been prevented. So a sizable portion of this medication errors comes from developing countries like India, and a lot of them actually come from our children, and we need to be very careful about it. What is the economic burden? It's humongous. The humongous amount of money is spent in managing these errors. Interestingly, in India, we don't have much data coming in because we are a very safe country. We don't have any errors happening. So we don't like to talk about errors. On the contrary, countries which are developed like the United Kingdom, their National Patient Safety Agency estimated way back in 2007, the cost for medication errors in their country was 750 million pounds. And adverse drug reactions consisted of a large portion of it. Now, what has this data done? This has forced the WHO to come out with a patient safety challenge, which is the third patient safety challenge, which is undergoing right now, which is medication without harm. So all my patient safety champions who are here attending know that the first challenge came in 2005 when we were talking about clean care is safe care. We were talking way back in 2005 that please wash your hands before you touch your patients. And came 2019 when COVID-19 taught us that before we do anything, we need to do our hand sanitization. So 14 years before, we actually predicted that there could be a pandemic which could kill millions of people around. And that was the result that WHO came out with. The first global patient safety challenge is clean care is safe care. The surgeons across the globe faced a huge difficulty of their patients falling to the surgical site infection, irrespective of great surgeries being done by them. So the WHO came together to form the second challenge in 2007 is safe surgery, save lives. So all the surgical hand wash and every other surgical safety checklist, whatever you see being implemented in hospitals, whether they're government or private in India and abroad, is because of this particular challenge. And currently, because of the COVID pandemic, this challenge got a bit derailed, is the medication safety challenge. And I congratulate Dr. Ratna Devi again for organizing this very important event where we are talking about medication errors in pediatric population. So what is a medication error? It is a preventable event, ladies and gentlemen. Please remember that we can prevent this error which may cause or lead to inappropriate medication use or patient harm while the medication is in control of healthcare professional, consumer, or patient. Now, what is very important is the organization which is giving the definition is the Institute of Safe Medication Practices in the United States. So anybody who's interested to look at what medication errors are happening in the world, please visit ISMP website, which is the global body to talk about patient safety practices as far as medication safety is concerned. What is the data as far as medication errors in pediatrics is concerned? If you look at the data, it's very sketchy. The largest study done till date is coming from Indore in Madhya Pradesh, where out of 1,286 children in the pediatric ICU, mind it, these are very sick patients who are in the pediatric ICUs, 457 errors were identified, of which medication errors were 69% of them. And majority of them is dosing errors. So next time you take out your teaspoon to feed your child, or I'm talking to my doctors or the nursing colleagues who are here, please be very careful on what dosing are you recommending to your patients, because this is a major problem in this country. And unfortunately, I would say that majority of the errors in Indore Teaching Hospital did not result in any morbidity, and they were mild in case. We have done our own research in West Bengal, in Calcutta, where we have published this paper, and I want to congratulate my management for allowing me to publish what medication error happened in a private hospital in Eastern India. And I think we need to have the sensitization to believe that we do make errors, but we need to learn from them. And we figured out that majority of the errors in children are because of dosing errors. The dosing which is done, even with due respect, by pediatricians sometimes is not correct. So we need to have evidence-based practice. We need to have prescription audits, and statistics coming again from Western countries clearly mention that medication errors happen in 1/3 to 2/3 of the cases. Now, a lot of kinds of errors happen. It could be prescribing errors, it could be dispensing errors, it could be errors related to transcribing. So maybe a senior pediatrician is taking a round and the junior is writing it on the patient file, but it's an organization which transcribes it onto an electronic database. While the transcription is going on, an error takes place. And finally, I would say there could be errors with respect to administration errors as well. There could be labeling errors as well. So I want to highlight everybody's attention to this particular slide that, ladies and gentlemen, if you look at the Swiss cheese model of risk analysis and management by Professor Reason, it clearly signifies that errors in your system identify faulty systems. They never identify faulty professionals. But unfortunately, in the world and including India, we try to always punish people who conduct error or who report an error. Please remember that every system, whether it's a government hospital or a private hospital, is like the Swiss cheese. It has a defect, and all these defects, when they come in a single line, so it is a new intern who's on a duty in an oncology ward where you have a nurse, senior nurse with large number of patients, and wrong dosing is written, which is not cross-checked by a senior postgraduate trainee, and it reaches the pharmacy where without checking it comes back and the double checking is not done, then a wrong chemotherapeutic dose reaches the patient. So what I mean to say is whenever we need to develop systems, we need to strengthen the gap within the systems. There is a lot of issues with polypharmacy in the pediatric patients, and polypharmacy, if you look at many of the patients who receives antibiotics, they are also on antihistaminics, and the increasing use of these medications in polypharmacy can result in errors and as well as adverse drug reactions. Coming to the second part of the presentation, what is this adverse drug reaction? It is defined by WHO as a response to a drug which is noxious and unintended, which can occur in doses normally used in man for prophylaxis, diagnosis, therapy of diseases or for modification of physiological function. Quite a difficult definition, but if I could break it down, so if you give any drug for prophylaxis, that means you are giving, say for example, for malaria prophylaxis, if chloroquine is given and the patient develops a side effect of chloroquine, a very commonly metallic taste in mouth, that is an adverse drug reaction. For diagnosis, certain in all of our radiology department, we are using a lot of intravenous dyes. In our MRIs, we are using it. In our CT scans, we are using it for diagnosing a tumor or diagnosing a disease. If that dye causes a reaction, that is also an adverse drug reaction. And therapy is whenever antibiotics or systemic therapies or local therapies are used and reactions happen, that could be an adverse drug reaction. So what are the known risk factors for ADRs in children? Polypharmacy, any child who's on more than 5 medication, very high risk of having an adverse drug reaction. If you already know that the patient is allergic to penicillin, be careful not to give cephalosporin in those patients. Interestingly, don't ask me the reason why, the female gender in children is found to be more sensitive to adverse drug reaction than the male gender. Impaired liver and renal function, and very importantly, off-label use of drug. Now, this is a major problem in countries like India, where people are using a particular drug in a very different dose, for a very different reason completely. And lastly is genetic polymorphism. Please remember that I believe India is 30 countries with one common flag. You know, the people in every region are different from the people who are living 500 kilometers away from each other. I'll give you an example. So the genes of Ratna Devi ma'am and my genes are totally different. So when an antihypertensive drug which can lower her BP might not lower mine, or an antihypertensive drug which produces an adverse reaction in her might not produce in mine. So we need to be very careful of our genetic makeup, and this is coming up very big in the practice and therapeutics, and this is known as pharmacogenomics. And it's a very important concept in children because we need to understand this. How do we minimize these errors? We need to implement electronic prescriptions. I know it's difficult in countries like India, but incorporation of computerized prescription order entry, and very importantly, clinical pharmacists required in the wards to do prescription audits to check whether we are dosing correctly or not. Now, another thing is medication reconciliation. Easier said than done. When a patient is entering the emergency, it's you have a certain group of medications which you're taking outside. It could be a homeopathic medicine, it could be an allopathic medicine, it could be an Ayurveda medicine, a Siddha medicine, which you have been taking for such a long time, which might have produced an adverse drug reaction for which you have now got admitted. That history needs to be told to the emergency medical physician. That drug, if required, that medication, if required, need to be continued. Medication reconciliation failure is one of the major cause resulting in omission or duplication of medication while the patient is moving within the system of a hospital or leaving the system. And very importantly, I think we need to understand that we need to educate the mother, we need to educate the parents, we need to educate the caregivers on how we need to use certain medications, how do we dilute certain medications, what is meant by water for injection, what is meant by dilutional component. We understand that people will understand everything. But the biggest problem with communication is that the illusion that communication has taken place. Please don't believe in that illusion. And very importantly, this is a very important thing, is how do we dose in pediatric patients? It's extremely important that we need to standardize dose by using standardized dosing chart or software, because in pediatrics, majorly we underdose. And this is detrimental in antibiotics. Many of the patients might not be able to fight bacterial infection because we underdose. We need to have pediatric specific formulation and adaptation, because, ladies and gentlemen, please remember, one size will not fit all. So many people will say paracetamol tablet 650 milligram for an adult. Can we break it into half and give it to a child? Answer is no, because we need a scoring of the tablet. And interestingly, the scoring has not been done. So 650 milligram broken into half will not become 325 milligram. Please remember this thing. And you cannot just give, half dosage. And lastly, I would say, what is pharmacokinetics? Pharmacokinetics is absorption, distribution, metabolism, and excretion. These are four important components. Children differ in absorption from the adults. Children differ in metabolism of the drugs than the adults. They also differ in elimination. We need to be very, very careful when we are dosing our children, because their bodies metabolize in a very different way. So they can retain a lot of medicines and they can have a lot of side effects. We need to also understand, ladies and gentlemen, what is the food being taken by the child? Because nowadays people are more into pizzas and pastas. Gone are the days of having our own Indian khichadis, because that is not a hep culture. So, I would say that all these pizzas and pastas, and especially if you're taking, I'm not going to name any brand, if you're taking a milkshake along with it, then you might not be actually helping the medication. So you might be on doxycycline, 8 to 17-year-old person, and you are taking a lot of milk with it, and you have actually retarded the absorption of that antibiotic, and your infection is not getting corrected. You are an epilepsy patient, but you are regularly not taking vitamin D because you have, bone pain. But you have to dose this correctly, or you might need to understand you have to take certain anti-epileptics which don't interfere with this. So another last thing I would say, in our country, we need to be very careful by implementing child-resistant packaging and safety. Very neglected by our pharmaceutical companies, and because we have seen in the horrific news in our media that how children open these cough syrup bottles and they gulp it down, and many of them have very, very catastrophic ending. Why is this happening? Because there is lack of child resistant packaging, and we are not taking this seriously. We are taking it for granted that the mamas and dadas are going to take care of this. Unfortunately, both might be back to work, whereas your child will be with a caregiver who might not be aware of all these things. So I would say a very important thing is to implement medication reconciliation in the pediatric wards, because if you miss this, you miss a very, very important thing. Because here, clinical assistant, pharmacists, they need to continuously review the chart and update the electronic medication records so that duplication of medication does not take place. Very, very common in case of tertiary care hospitals. So to summarize my presentation, I would say errors in prescribing, dosing, administrations are the leading cause of preventable harm in pediatric populations. Ladies and gentlemen, please remember, next time you come across a medication error, always remember that this is signifying a faulty system. It's not that nurse, it's not that doctor, it's not that pharmacist who caused it. Electronic prescribing systems, double checking protocols for high risk medication, medication reconciliation, and caregiver education significantly reduces this risk. But this involves not only medical protocols, but very importantly, I believe, we need to educate the society. And I again thank Dr. Ratna Devi for playing for the patient. She's a staunch patient advocate. I think what we need is to empower patient education, patient empowerment, take the help of technology. And with this, if the policymakers come together along with community, that can be the best world where our children can be safe. And that's what we all aspire for. Thank you very much for this opportunity. Looking forward to any interaction. Dr. Ratna, you are muted.
I'm sorry. Thank you so much. Very elucidate, as always. A lot of very interesting and very important points raised. But I'd just like to go back to Dr. Ajay Khera, if he's still present, on the issue of neonatal sepsis. And this is something that's extremely important. And there is an interplay between vaccination, nutrition, medication, availability of proper medication, and neonatal sepsis, and why neonatal sepsis is a medical emergency that needs to be addressed as early as possible. We do know that within the government health programs, we do have the Mong centers, etc., but we still find that children are not reported early, diagnosed early, and treated early. So, in your opinion and with your experience, what more can be done to prevent neonatal sepsis, and how can we best address this problem, especially with community involvement?
Thank you very much, raising this point of neonatal sepsis, because if you look at those available data sets, around 30% of the neonatal mortality is attributed to sepsis. And maybe around 30 to 40% is attributed to something called as the neonatal asphyxia. And then there are rest of the reasons. So neonatal sepsis is one of the important cause of neonatal mortality. Now, in order to prevent this kind of a preventable illness and to reduce neonatal mortality, as Dr. Naveen Thakkar also mentioned, because this is related to a kind of infection prevention. That means using all hygienic measures, particularly in the labor room where the deliveries are happening. You have to follow a system of asepsis techniques are to be followed. And it is not only that during the delivery, asepsis has to be followed, even for the newborn care also. That's why we keep recommending even to the parents that you have to wash your hands. And this is particularly, quite common problem, particularly when the child is low birth weight or child is preterm. And the numbers of, low birth and preterm children born in India are also not less. Again, to the tune of 20 to 30%. Every third child born is kind of a preterm or a low birth weight. It's a huge problem because of the undernutrition of the mother. It's a kind of an interplay. So that means if a preterm child, low birth weight child, if the proper hygienic precaution is not taken, they are more prone to infection. And then I also spoke about something like breastfeeding as a vaccine. If on the top of it the mother is not breastfeeding their child, the newborn doesn't have that enough immunity. And we continue to say that breastfeeding provides that immunity to the child, and that prevents infection. So I will say, number one, clean hygienic measure is one intervention which has to be practiced universally, whether the child is preterm, low birth weight, or even a healthy child. And then the second, the intervention is, continue to promote breastfeeding. Breastfeeding is a vaccine to prevent sepsis. It is a kind of a universal vaccine actually. It is not for a particular disease, because the mothers, the so-called the colostrum contains large number of antibodies. So it is a kind of a provides protective protection to the newborn. So that is promoting, breastfeeding is the second. And then the third important thing, which happens, as again Dr. Naveen Thakkar told, that sepsis is a condition in newborn which does not represent typically like, fever, because generally in a sepsis case you find a fever. But here in the newborn cannot speak, and even the fever is not manifested, and there is something called as the hypothermia. The temperature goes down, the cold and the clammy skin, and then the child is not accepting any feed. You don't know what is the reason. So I think any suspicion of this kind, if there is a hypothermia, or child is not accepting feed, child is to be immediately suspected as sepsis, and then immediate attention has to be given, whether to the nearest hospital or nearest health facility, even to the extent that government of India came up with a kind of injectable gentamicin as a one of the intervention,
Yes.
which can be given to a newborn, suspected newborn case,
We,
in a neonatal sepsis, which can really make a change, drastically, and particularly where the health facilities are quite far away. We have empowered, the ANMs to give those injectable gentamicin. There was a lot of, kind of a debate, discussion took place that unnecessary antibiotic should not be given. Yes, it should not be given, but sometime, in a public health setting, I'm again saying, in a public health setting, you have to weigh, risk versus benefit. So it is not that this is a practice which will be there for years to come. Maybe, 5 years down the line, or in another 10 years, our health system will become so robust that our health facilities are near to the homes of the people. Then we may not require to, empower ANMs to give gentamicin on a slightest suspicion. So early diagnosis and referral, breastfeeding, and then hygienic measures. These are the three things which has to be kept in mind to reduce the load of neonatal sepsis in the community and thereby improve their survival. Thank you.
My question to Dr. Bhaumik, and you raised this very important issue of dosage. And the general misconception is the child is a small adult. And that is why the adult dosage can be sort of divided into portions that can be given as per the age of the child. The other problem is, of course, the non-availability of child-specific formulations. So a lot of tablets that are available in the adult dosage are not available in syrup forms or in dispersible forms for children. And having said this, there is also the problem of low health literacy. So many of these mothers or children or parents of children do not actually read the labels and therefore do not know what 1/4 is. They look at the tablet as a whole, but not the formulation that is there. So how many grams, how many milligrams? Nobody reads that. They just think 1/4 tablet or 1/10 tablet or whatever it is. So what can we do as patient advocacy organizations to improve this form of health literacy and help people understand why adult formulations are not, useful for children?
I think that's a great question. Personally, I believe that a lot has to be done by the pharma industry because we need to have advocates from the industry to also speak about this. And this is like how do I put it? I think it's something like wearing the helmet. It cannot be said that, you can drive a two-wheeler without wearing a helmet. So without having child-specific formulation and you're launching it into the market, and, this is something which is very detrimental. And I don't want to criticize anybody here, but then I think the drug regulator in the country has a very important role to play here. That, we just can't launch products which are there in other countries because we are different. India is different. Indian people are different. Our genes are different. So, so we need to have number one, child specific formulation. Secondly, I believe again, when it comes for certain group of medications, I'm very concerned about antibiotics. Dr. Khera mentioned about antibiotic usage. I completely agree, the risk benefit analysis and usage in public. But in public hospital, I have worked in public hospital. My entire training has happened in public hospitals in the city of Calcutta. But having said that, a very important role has to be played by the community pharmacist who are there, dispensing medication at your mohalla. Many of them are not even pharmacists. So they are like, अरे कुछ नहीं कर रहे हो तो यहाँ इसको बिठा दो, like जो गल्ला देख रहा है वही, the person who's actually looking at the money, he's probably a class 10 fail guy. He's now telling, okay, गले में दर्द है तो फिर आप एक amoxicillin, azithromycin, let me name azithromycin. So the azithromycin sensitivity in India is down from 95% in 2000 to below 55% in the year 2020. And who has done this? I mean, it's the pharmacists, so-called pharmacists who are dispensing without any Schedule H1 regulation. So a very important role can be played by your organizations to run campaigns, training campaigns for these mohalla pharmacists who claim to be pharmacists, and they don't have any idea in terms of when you ask them, then say, "Acha, aap ABC medicine le jaiye, uska aadha you." You put the half tablet or you take half teaspoon. I mean, we need to educate these people. The other important role, I strongly believe in India's public health system. We have done remarkable work in our country through our Anganwadi workers. We have done remarkable work through Asha workers. In fact, many success stories from Jharkhand, from down south, including West Bengal, are there where Anganwadi workers, when they looked at nutrition also, they have been able to do a lot of change. So I believe that some basic group of medications like the cough syrups, which that there's a lot of spurious medications in the Indian land as well, speculated that if they could identify, they go and they talk to the parents, because Anganwadi Didis and workers, the Asha workers, they are like a home person. They are like accepted by the mothers, the grandmothers, and the fathers of the child, and they talk about that when don't dose yourself, don't self-medicate, dawai mat dijiye, don't self-medicate, and in terms of don't go for the cheapest brand. Sometimes people are going with the cheapest brand, and look at government has issued, like in state of West Bengal, we were facing a lot of spurious drugs. So the state of West Bengal has issued a list where I think the list should reach the people who can understand it. Use our vernacular languages. As I told you, very importantly, English is not our language. It's a language for communication because that's how we have been born and brought up. But speak in the language in which our people can understand. Use Hindi wherever possible. Use the local language. Train the local people. And I'm a strong believer that we must keep our own data. These Anganwadi workers, if they start reporting, I believe that, the reactions also, if they are coming through any kind of reactions, then the public health system, which is so well developed, this can act as a very important surveillance tool for India as a whole. So we can engage these very, very important stakeholders, school teachers, for example, the primary school teachers who are there, who are seeing that, okay, a child has taken a medicine and there is a discoloration in the child's face. Aapko kya hua? What did you happen? So I took this medicine and I had this reaction. Maybe the father and the mother is not able to identify, but this person is a graduate. He or she reports it to the local mohalla doctor or to the primary health center. So we need to actually, in fact, the government does allow reporting in through the pharmacovigilance program of India. We need to utilize all these kind of resources.
Thank you, Dr. Bhomik. And the last one is, of course, the child-resistant packaging, which is a no-brainer. And I hope we can all collaborate to advocate for child-resistant packaging, because this is the mandate in almost all the developed world. However, we don't see this even for basic, high-risk medications there in India, which sometimes are sold without prescriptions over the counter. So thank you all for joining us today, and thank you for your insights. It has been a truly insightful discussion, lots of good points coming up, and we will share the report with you in due time. Thank you all, and thank you. Have a great evening. Have a great rest of the day. Thank you so
Thank
much.
you. Thank you. Thank
Thank
you.
you. Thank you.
Thank
Thank
you.
you.
Thank you.